Someshwar Garu, now we can start webinar.
Is it live?
Yes.
Yeah, thank you, Savan. Yeah. Good evening, doctors. This is Dr. Someshwar from Shield Healthcare. I welcome you all on behalf of Shield. Thank you very much for joining today's webinar. I request all the delegates to please do comment your questions in the comment box so that at the end of the webinar, we'll have a short Q&A session. So now let me welcome our today's eminent speaker, Dr. Swetha Thumula ma'am, who is a ART specialist and chairman at Eva Fertility Center, Hyderabad. And she have done her fellowship in reproductive medicine from University of South Alabama, USA, and ART fellowship at Center for Reproductive Medicine, Florida, USA. And also she have done advanced ART training at Cleveland Clinic, USA. And also coming to the associations, she's a member of FOXY, IFS, ICER, ISTRE, and ASRF. So with this, we welcome you for today's webinar, ma'am. And coming to the today's webinar is streamed through the Shield Connect, which is the digital platform of Shield. And if you miss any part of the program, it will be available in the Shield Connect webpage. And also it will be available in the Shield Connect page in the YouTube. And coming to the today's topic, the principles and practice of controlled ovarian stimulation in ART. So without wasting much time, let me turn over the time to Dr. Swetha ma'am to talk on principles and practice of controlled ovarian stimulation in ART. Over to ma'am.
Thank you, Dr. Someshwar. Firstly, I would like to thank Shield for organizing this webinar. So as Dr. Someshwar has told, today we will be discussing on principles and practice of controlled ovarian stimulation in ART. Assisted reproductive technologies, they have substantially advanced since the birth of the first IVF baby. So since then, there have been many innovations which have been taking place in our IVF laboratories to increase our success rates. So one of the milestones in the history of IVF would be undeniably the introduction of ovarian stimulation, which improved our pregnancy rates as compared to the very low pregnancy rates which we were getting with the unstimulated cycles. On that note, we would understand what is controlled ovarian stimulation, what is the efficacy of ovarian stimulation, and also we would understand how to individualize our ovarian stimulation protocols. Evolution is a slow change which happens at every part of the time. So it was the first change which came was the delivery of the first IVF baby on July 25, 1978 in UK in Oldham near Manchester. So this first IVF baby was born through a natural IVF cycle. So it was due to the relentless efforts of Patrick Steptoe and also Bob Edwards that this miracle has taken place. So since then, there has been much research going on in the field of ART. Clomiphene citrate was introduced as an ovulation induction agent for anovulatory women as early as 1979, and by the end of 1981, clomiphene citrate was widely used as an ovulation induction agent, and also many pregnancies were documented. In 1982, HMG and GnRH agonists were introduced, and they had a very good pregnancy rates with HMG and GnRH agonists. In 1991, GnRH antagonists were introduced, like cetrorelix and ganirelix were introduced into our ovarian stimulation protocols to prevent that LH surge. And they also observed that the pregnancy rates were similar when compared to GnRH agonists. In 2011, we all know this breakthrough paper, which was published by Paul Defroy, where he has given a concept of an OHSS free clinic bisegmentation of IVF treatment. OHSS, which was once considered as a nightmare for the clinicians, now it can be completely overcome or it can be completely erased by giving a GnRH agonist trigger in the GnRH antagonist protocol, followed by vitrification of the oocytes or the embryos, which can be used at a later date. So since 2011, there has been many refinement in our ovarian stimulation protocols. So this picture shows the concept of FSH threshold and window. So the arrows which we can see here are the growing follicles. So in a spontaneous cycle, whenever a dominant follicle is emerging, the FSH levels rise, and as the dominant follicles grow, they fall, leading to a monofollicular development, and all the other follicles, they get ectritic. But when seen in a conventional cycle, when it is stimulated with exogenous HMG or FSH, so the aim in a conventional IVF cycle is to get a multifollicular development. So what happens here is the FSH window is extended as the follicles, as many follicles are recruited, the FSH window is extended, and the FSH levels, they rise above the threshold, and the plateau is maintained, resulting in a multifollicular development. In a mild stimulated cycle also, the same mechanism takes place, but with a lesser number of follicles when compared with a conventional cycle. So the HFEA has collected data prospectively from all the ART cycles performed in UK from 1991 to 2011. So they have analyzed around 584,000 IVF cycles which were stimulated and 6,000 unstimulated IVF cycles. So they have looked into the oocyte number and also the embryos created from these cycles. They have found out that around 44.2% of the unstimulated cycles do not have any oocytes retrieved versus 7.1% of the stimulated cycles which do not have oocytes retrieved. So when compared to the embryos created, 57.1% of the unstimulated cycles, they fail to create embryos versus only 11.9% of the stimulated cycles. When they have looked into the live birth rates and also the singleton live birth rates per cycle in both the stimulated and unstimulated cycles, they found out that the live birth rates and the singleton live birth rates were higher in a stimulated cycle when compared with an unstimulated cycle. So analysis of this large data set demonstrates that ovarian stimulation has a vital role in maximizing the efficacy of IVF. The introduction of ovarian stimulation into IVF, it has been a vital clinical milestone to increase our success rates. So currently, majority of the IVF cycles, they involve ovarian stimulation, which is aimed at optimizing the number of oocytes retrieved. Number of oocytes retrieved influence substantially the prognosis for the success of IVF treatment. Ultimate objective of all our ART treatments is to efficiently achieve healthy live birth outcomes. So this was a blood study conducted by Sage Sankara, where they have analyzed around 4,000 IVF treatment cycles. They have looked into the association between the live birth rates, which was considered as a success marker for IVF. They have looked into the association between the live birth rates and also the number of oocytes. So you can see from the picture here, as the number of oocytes increase, there is an increase in the live birth rates. So in this study, they have included only the fresh embryo transfer cycles. So that is why after a certain extent of the number of oocytes, there is a decline in the live birth rates. But there have been many innovations which have been taking place in the ART lab, and thanks to the vitrification techniques, which have evolved over a period of time. And now we have such robust vitrification programs that we have 100% survival rate of our thawed embryos. So as such, from the live birth rate, which was considered as a marker for our ART success, we have stretched it a little bit to cumulative live birth rates. Cumulative live birth rate is the live birth rate resulting from one initiated or aspirated ART cycle, which includes all the fresh and the frozen embryo transfers, until one delivery with the live birth occurs, or until all embryos are used, whichever occurs first. So while we are treating all our infertility patients, it is important for us to understand that the fertility treatment should be given in a timely manner. That is why it is important for us to understand the term time to pregnancy. It is the time taken to establish a pregnancy, measured in months or in numbers of menstrual cycles. So it is important for us to maximize our IVF success rates by decreasing the time to pregnancy in all our infertility patients. So this is a study where it was conducted across 15 centers in Spain and Belgium, where they have taken around 15,000 women undergoing first ovarian stimulation for IVF and ICSI. They have looked into the cumulative live birth rates and number of oocytes. Cumulative live birth rates, as we have understood, that it is both the fresh and frozen embryo transfer cycles are taken into account. So from this picture, we can see that as the number of oocytes increase, there is an increase in the cumulative live birth rates. So the maximum cumulative live birth rates are obtained when at least 25 oocytes are retrieved from women in the age group between 18 to 34 years, and around 30 oocytes are retrieved in the women between 36 to 44 years, and around 9 oocytes to be retrieved in women more than 45 years of age to achieve that maximum cumulative live birth rates. So the time to pregnancy is increasingly recognized as an important outcome to measure the effectiveness of all our interventions. So our main important aim is to reduce the patient burden and make our ovarian stimulations more cost effective. But how do we make this more cost effective is to select a stimulation regimen in which we produce more number of oocytes so that we increase our cumulative live birth rates and decrease our time to pregnancy. So what should be the goals of ovarian stimulation? So it should be, first goal should be to maximize the efficacy of our ovarian stimulations. So how do we do that? Is by improving our live birth rates. And also the important thing is to reduce the complications and risks by reducing our cycle cancellations, reducing our treatment burden, and also decreasing OHSs. So whatever stimulation program or the regimen we choose, it should be simple, it should be cost effective, it should have minimal side effects, and it should give the best outcomes. But how to tailor our ovarian stimulation programs? Is it that we put all our patients on the same ovarian stimulation regimen? Or are there any parameters that are need to taken into account before starting on with the ovarian stimulation? So majorly the age of the patient, ovarian reserve markers, and previous response to ovarian stimulation is taken into account before starting of ovarian stimulation to tailor our ovarian stimulation protocols. As all of us know, as the age advances, there is a decrease in the oocyte quality. It is because the mitochondrial function becomes impaired. There is more and more of granulosa cell apoptosis, which takes place with increased age, and also the oxidative stress is increased. So combined all these things, there is a decrease in the oocyte quality as the age of the patient advances. And also it is well known that as the age advances, there is a decline in the oocyte yield. That is, the number of oocytes we get from a patient also decreases with increasing age. So why is it important for us to assess the ovarian reserve markers before starting an ovarian stimulation protocol? So we have many ovarian markers. We have the hormonal biomarkers, which are FSH, inhibin B, and AMH. Functional markers are AFC. Genetic biomarkers are single nucleotide polymorphisms for FSH receptors and LH receptors. So why is it important for us to assess these markers, and how does it impact our ovarian stimulation? So ovarian biomarkers help us to classify our patients and also predict the ovarian responsiveness to gonadotropins. They also help us to tailor our ovarian stimulation protocols, and they also help us to prevent cycle cancellation and decrease the chances of OHSs. AMH and AFC are the preferred methods for predicting the ovarian reserve. They reflect the number of non-growing follicles in the female ovary. Both AMH and also AFC, they provide a very good prediction of poor and excessive ovarian response. As all of us know, antral follicle count is quick. We can do it by ourselves. It is non-invasive, but there is large inter-operator variation. AMH on the other side is objective, and but this AMH assays have been evolved over a period of time, and presently maybe they have a little, they have become a little standardized. So by taking into account the patient's age, the response to ovarian stimulation, and also the ovarian reserve markers, we have categorized our patients into 3 groups. We have categorized our patients into 3 groups. It is like we have come from a stage of one size fits all to an individualized ovarian stimulation protocols. So why are we grouping our patients into these 3 groups is to know the prognosis of these patients and also to explain the patients how they respond to the ovarian stimulation protocols. So they are grouped into high responders, normal responders, and poor responders. When the AMH is between 3.5 to 5 and the antral follicle count is more than 15, they are termed as high responders, and the main objective in this group is to minimize the OHSS risk. When the AMH is between 1.2 to 3.5 and the antral follicle count is between 5 to 15, the patient is termed as a normal responder. And the main objective in this group is to maximize our success rates by taking a good protocol. And when the AMH is between 0 to 1.2 and less than 5 antral follicles are seen, the patient is termed as a poor responder. So the main objective in this group is to minimize the treatment burden, choosing the right protocol, and also choosing the right dosage of FSH stimulation. So for any ovarian stimulation protocol to achieve that maximum success rate, it requires 2 factors, efficacy and also efficiency. Efficacy is increase in the number of cumulative live birth rates by increasing the number of oocytes. Efficiency is how far we are able to decrease the negative events, that is, decrease the multiple pregnancies, decrease in the incidence of OHSS, and also decrease in the incidence of abortions. So by optimizing our ovarian stimulation protocols, we are able to decrease the time to pregnancy in these patients. But how is that we improve our efficacy and efficiency of our ovarian stimulation protocols? It is by individualizing our ovarian stimulations, by choosing the right protocol for the right group of patients, by choosing the right gonadotropins, the type, and also the dosage, and also by giving the right trigger for the right group of patients. Why is it important for an individualized treatment? As you can see from the picture over here, the area which is present on the left side of the red line, it shows a poor response from the patient, and the area which is present on the right side shows a hyper response from the patient. So the area which is in between the 2 red lines is the optimal response from a patient. So it is important for us to individualize our treatments to avoid extremes of response. That is, we don't want a poor response from a patient, and also we don't want a hyper response from a patient. So by individualizing our treatments, we also reduce our cancellation rates. We also reduce the risk of OHSS. So the regular protocols, what are followed now for controlled ovarian stimulation, we have the conventional protocol when we retrieve more than 8 oocytes. In that we have the long GnRH agonist protocol, where there is an initial flare followed by pituitary down regulation. Second is the GnRH antagonist protocol, where there is a direct gonadotropin suppression. We have a mild stimulation protocol where the ovulation induction agents like clomiphene or letrozole are used. They are used for initial 5 days of the stimulation, and from day 6 of the stimulation, gonadotropins are started. And once the lead follicle reaches 14 mm, GnRH antagonist is given. So there are 45 RCTs which have compared the antagonist and also the long agonist protocols. So they have found out that there was no significant difference in the live birth rates or the ongoing pregnancy rates, either you use a GnRH antagonist or an agonist protocol. But with the GnRH antagonist protocol, there is a large reduction in the OHSS because there is a flexibility of giving a GnRH agonist trigger and doing a vitrification. In GnRH antagonist stimulation protocol, we have a fixed protocol and a flexible protocol. Fixed is we start the GnRH antagonist stimulation from the antagonist is started from the 6th day of the stimulation, and flexible is we start GnRH antagonist when the lead follicle reaches around 14 mm. So when they have done a meta-analysis, they have found out that there are similar pregnancy rates and also similar number of oocytes were retrieved. Either you start with a fixed protocol or a flexible protocol. So there has been much debate regarding what type of gonadotropins to use. It is important for us to know that whichever regimen is chosen, the gonadotropin preparation which we use is reliable and is of consistent quality. So the gonadotropins, which are filled by mass technology, they result in more consistent ovarian response. We have a very large trial, that is a Megaset trial, which has compared the HMG with recombinant FSH in a GnRH antagonist cycle. So the conclusions were that whether you use a HMG or a recombinant FSH, the ongoing pregnancy rates are not going to change. But with the recombinant FSH, the yield of oocytes is a little more when compared to HMG. So this is a study group where they have categorized the patients depending upon the number of oocytes retrieved. Group A has in Group A they have retrieved 1 to 3 oocytes. Group B is 4 to 9 oocytes. Group C they have divided. They have retrieved 10 to 15 oocytes, and Group D more than 15 oocytes. So Group A, where they have retrieved only 1 to 3 oocytes, we would term them as poor responders. Group C, where they have retrieved 10 to 15 oocytes, is the optimal number of oocytes. So we would term them as optimal responders. Group D, more than 15 oocytes, then we would term them as hyper responders. But Group B, where there only 4 to 9 oocytes are retrieved, they are neither poor responders nor an optimal responders. So we would categorize them as a suboptimal responders. So there should either be a poor response or an optimal response or a hyper response. But some of the patients we see in our clinical practice have this suboptimal response. So why are some of these patients having a suboptimal response? So when we take two patients having same AFH and same AMH and also same AFC, and stimulate them by following the same ovarian stimulation protocol with the same dose of gonadotropins, as you can see here, the first patient responds normally. That is a follicular output rate, which is the ratio of the pre-ovulatory to the small antral follicles, is around 40 to 60%. So that is, she is a normal responder. She has responded normally to our ovarian stimulation protocol. The second patient, who is having the same characteristics as the first patient, responds in a different manner. So her follicular output rate is only 20 to 30% as compared to 40 to 60%, which was present in the previous patient. So why is that? Some patients are having this hypo response. So follicle oocyte index is also taken, which is the ratio between the number of oocytes retrieved at oocyte pickup and the number of antral follicles at the start of stimulation. So normal FOI is at least more than 50% of the antral follicles should translate into oocytes. Low FOI is less than 50% of the antral follicles have translated into oocytes. Possible causes may be we have given a low gonadotropin starting dose, maybe genetic or environmental factors. It may be because of asynchronous follicular development. There might be some technical issues during the trigger, giving the trigger, or there might be technical issues during the oocyte pickup. So there are some terms which we need to understand. Is a patient with a good ovarian reserve may have a poor ovarian response. A patient with a poor ovarian reserve may have a good ovarian response. So the hyporesponse in these patients, what is the reason for the hyporesponse in some of our patients? Hyporesponders are women with normal ovarian reserve, but they have a different sensitivity to FSH and LH. So the hyporesponse in these patients is mainly because of the polymorphisms seen in FSH receptors. The serine 680 is the most common polymorphism which is seen in these hyporesponders. And what happens when there is a FSH polymorphism or a beta LH variance? So the FSH consumption is higher in these patients when compared to the normal population. So to overcome this, the Poseidon group has given a new, more detailed stratification of low responders to ovarian stimulation. They have given a concept from a poor ovarian response to a low prognosis. According to the Poseidon classification, 4 subgroups have been suggested based on the following quantitative and qualitative parameters: age and the expected aneuploidy rate, ovarian biomarkers, that is AFC and AMH, ovarian response if a previous stimulation was performed. So what is the aim of this Poseidon classification is to help the clinicians counsel the patients and also to set the patient expectations and to establish a working plan to reduce the time to pregnancy. According to Poseidon criteria, Poseidon group 1 is young patients less than 35 years. They have good AFC and also AMH, but they have an unexpected poor or suboptimal ovarian response in their previous cycles. Poseidon group 2 are older patients more than 35 years of age with a good AFC and AMH, and they had a suboptimal ovarian response. Poseidon group 3 are young patients less than 35 years. They have a less AMH and AFC. That is, AFC is less than 5 and AMH is less than 1.2. Poseidon group 4 are the older patients more than 35 years of age with less AFC and AMH. So the Poseidon classification group 1 and group 2 patients are those patients where we have a good AMH and also AFC, but they had a response which is not expected of them. We were expecting a normal response from these patients, but these patients showed an unexpected impaired ovarian response. So what to do in these patients? So while stimulating the patients, we see that on day 5 or day 6, the follicles are not coming up. So this might be a hyporesponder patient. And what is the other intervention we are going to do is add a recombinant LH of 150 IU, which is started on stimulation day 8, and it is given till the day of the trigger. So with recombinant LH, when it is added to recombinant FSH, we have seen higher implantation rates and also higher clinical pregnancy rates are obtained. And the dose of FSH, so whenever there is a hyper response, it is not advised to increase our dose of recombinant FSH, but instead recombinant LH is added to increase our outcome. So the FSH dose should be around 300 international units and not more than that, because studies have shown that higher number of oocytes were retrieved when the FSH dose is around 300 international units when compared to 150 or 450 or 600 IU. And also when the dose of 300 IU of recombinant FSH is used, there were significantly lower cancellation rates than the other doses. So how does the LH increase our IVF outcomes? When recombinant LH is added through androgen production, it improves the granulosa sensitivity to FSH and increases the number of FSH receptors and thereby increases our outcomes. The Poseidon classification in women group 2 and also group 4, where the age of the woman is more than 35 years of age. So when the patient is having an advanced age 35 to 39 years, and when she's showing a hyperresponse, we can add either a recombinant LH. 75 IU is started on stimulation day 1 and it is continued till the trigger day. Or we can add 150 IU of recombinant LH, which is started on stimulation day 6, and it is continued till the trigger day. In patients with in patients with Poseidon group 3 and also group 4, where the AMH and also AFC are very less. So in these patients, we have so many other options. Either we can go for a mild stimulation IVF, which is done in the follicular and also luteal phase using the ovulation induction compounds like clomiphene, letrozole, along with gonadotropins, or we can go with the Geostim protocol. So in the Geostim, the gonadotropins are started from day 2 of the cycle in a GnRH antagonist protocol. After the lead follicle reaches 14 mm, GnRH antagonist is given, and GnRH agonist trigger is given, ovum pickup is done. So a gap of around 4 or 5 days is given, and then again the patient is stimulated in the luteal phase, again with the same protocol, GnRH antagonist protocol. The GnRH agonist trigger is given and the ovum pickup is done. So similar number of euploid blastocysts were obtained after follicular phase and also the luteal phase stimulation. Addition of luteal phase stimulation, it significantly increased the transferable blastocysts when compared to only the follicular phase stimulation. So when it comes to the hyperresponders, these people are young age, AFC more than 20, AMH is obviously more than 3.5. Most of the times these are patients of polycystic ovarian syndrome. The objective in these patients is to prevent OHSS. What are the options we have is triggering ovulation with GnRH analog and giving a good luteal phase support. So what protocol to be used in patients with PCOS is the GnRH antagonist protocol, which has to be used, which has the flexibility of giving a GnRH agonist trigger so that we can reduce the OHSS rate by around 50%, vitrify the oocytes, and they can be used in the next cycle. What happens when GnRH agonist is given for a trigger? GnRH agonist displaces the antagonist from the receptors in the pituitary and triggers both LH and also FSH surge that stimulates the ovulation and also final oocyte maturation. So when GnRH agonist trigger is given, it has a sharp rise and also a fall. So this results in a drastic luteolysis in the second half of the cycle. So that is why the pregnancy rates are a little less when GnRH agonist trigger is given and a fresh embryo transfer cycle is done. So with GnRH agonist triggering, there are many RCTs which show that there is a very low incidence of OHSS, or the OHSS incidence is completely zero after giving a GnRH agonist trigger. So what is the benefit of GnRH agonist trigger is a decrease in the incidence of OHSS. We have got higher fertilization rates, higher implantation rates, and also it is more physiological. So controlled ovarian stimulation with gonadotropins produces multifollicular development. Controlled ovarian stimulation entails prediction, counseling, and individualization. Patient characteristics and ovarian reserve tests are to be taken to individualize our stimulation regimens. AMH levels are superior to other markers of ovarian reserve. Gonadotropin dose should be based on the patient's age, characteristics, and ovarian reserve. Pituitary down regulation with gonadotropin receptor analogs is essential to prevent premature ovulation. Recombinant gonadotropin preparations are more potent and they result in an increased oocyte yield. Conventional stimulation, when it is done within the acceptable limits, it is safe and efficacious. Thank you.
Thank you very much, ma'am, for the wonderful presentation. And you have given a clear understanding of the science of reproductive technology behind this stimulation protocols and latest therapies, defining their current relevance to the treatment, also covered the practical guidance, along with also covered the latest research done in this field. Thank you very much, ma'am, for the wonderful presentation. Ma'am, if you allow me, then we'll take the questions.
Yes, yes.
Yeah, thank you, ma'am. Ma'am, we have a first question. The delegate, that is lady married for 2 years, AMH more than 5, LH10 with no response to oral stimulation. Should we go for LOD?
Right.
Hello? Yes, ma'am.
Hello, can you hear me?
Yes, ma'am. I can hear you, ma'am. No.
Yeah. AMH 5 and
AMH is more than 5, LH10
Mhm.
with no response to oral stimulation.
Mhm.
Should we go for LOD?
Yes, first maybe you should add oral stimulation with gonadotropins and see, and then also if she's with the induction agents plus gonadotropins, then you can do a laparoscopic ovarian drilling for these patients.
Thank you, ma'am. Uh,
Someshwar garu,
yeah.
any questions now further?
Yes, we are waiting for the questions for now.
Okay.
We just had one question. We are waiting for a question. Ma'am, I think there are no more questions from the delegates, ma'am.
Okay.
If you allow me, then we'll close this webinar.
Yeah, sure.
Yeah. Thank you very much, ma'am, for the wonderful talk. And we will look forward for your continued support for this educational
Yeah,
initiative. Thank you very much, ma'am, and
thank you.
many thanks from the Shield team.
Thank you.
Thank you.